we're excited to have all of you to kind of kick us off. I also just wanted to quickly introduce Gabriel, Angela, and Savan. They've all been helping me in like putting together this event, and definitely look forward to working with them as we kick off the new year. So without further ado, I'm going to pass it on to Angela, who's going to introduce our first speaker, and then Gabriel, who's going to introduce our second speaker.
Hello, everyone. Welcome. I would like to introduce Dr. Zach Hettinger, who is the Director of Cognitive Informatics for the Mental Health National Center for Human Factors in Healthcare and an Assistant Professor of Emergency Medicine at Georgetown University of School of Medicine. He's dual board certified in emergency medicine and clinical informatics. In these roles, Dr. Hettinger has the opportunity to translate between the languages of medicine, informatics, and human factors with the goal of improving patient safety and healthcare processes. His primary interests include health information technology, adverse event analysis, and data visualization as they pertain to reducing hazards in the healthcare environment. So Gabriel, would you like to introduce Dr. Crossley?
Yeah, sure. So Dr. Jason Crossley is a current otolaryngology head and neck surgery resident at Medicine Georgetown. Dr. Crossley graduated from Georgetown University School of Medicine in 2019 and has published work centering around prescription and medical device approvals. He is currently investigating the use of machine learning software to improve surgeon preparation in neuro-otologic surgery and to improve accuracy in determining which cancer patients may benefit from head and neck surgery. Dr. Hettinger and Dr. Crossley, thank you for accepting our invitation. Dr. Hettinger, the floor is yours.
Thank you very much. Can you give me a thumbs up if you guys can hear me okay? Good, okay, excellent. So I'm taking a little bit of a broader approach and talking a little bit about how we're using big data within MedStar Health and some of our other research projects to understand the applications of machine learning and getting a little bit more into the case studies and kind of how I got to this point. We have other team members, if you guys want like the gory detail and getting into like Python and RStudio and manipulation of data, that's not me. I used to do coding before medical school, and then I've since lost all of those skills. So I work with really smart people and act as a translator. So I will try to advance my slides and see if that works great. Disclosures, a bunch of different grant funding that I'm happy to talk to people about afterwards, but currently not taking any industry funding. So I want to do a quick brief background on myself, just because I feel like for medical students, as you guys are planning out your career and not only just your specialties, but how you want to incorporate informatics in your medical career, I think that's helpful. A little bit about human factors engineering, which is kind of how I got into this path, and then a couple of big data case studies and how we're applying machine learning techniques. So brief background, I trained University of Rochester Medical School. Did that for medical school and then went there for residency and then stayed for a 2-year research fellowship. And I went down this pathway because I had a kid that I took care of that I wrote the wrong order on. I ended up seeing this kid. I had a couple kids that I was taking care of at that time, little baby that didn't need any imaging. And then there was a teenager that had fallen off a horse, had a head injury and needed a head CT. And I wrote the order and saw the kid getting wheeled by, approximately 1.5 years old. And the technician, the transport technician said, oh, he's going to go get his head CT. And at that point, stopped him, made sure the kid did not get a head CT that they did need. But that really set me on this pathway to understand how we can use informatics and big data to really understand EHR usability and how we can design safer systems. So thankfully, the kid did not get the head CT. I went from doing the fellowship to becoming dual board certified in emergency medicine and clinical informatics, grandfathered in, I think it was 2014. I got a master's in clinical investigation, which is kind of basic research study design. Went through the American Medical Informatics Association's 10x10 course, which I highly recommend once you get out into practice. You can look at it now, and then get that board certification in clinical informatics. And my approach has really been focused around cognitive informatics. It's kind of a new emerging area of how we use large data to understand the way that humans interact with health IT systems. And I'm not going to go into detail, but I have been recipient of the NIH Loan Repayment Program, which as you all are kind of going through your medical training, I know that paying for medical school is definitely maybe not top of mind now, but certainly something that you're thinking about. And it's a great program. And basically at the end of my stint, and I've almost paid off all my med student loans through the NIH loan repayment program, which has been fantastic. So reach out to me if you have any questions. So briefly, human factors engineering. Again, this talk's not long enough to go into those details, but it's essentially how we use what we know about human cognition to design systems that work well. And all of you have probably had the experience of pushing on a door when you're supposed to pull, or pull when you're supposed to push, or you've been in the shower where you've been fiddling around the handle, probably pre-COVID, before all these travel restrictions were in place. But that experience of working with an interface and kind of trying to manipulate whatever the device is, whether it's a door, shower, or in this case, EHRs, that those design cues lead you astray oftentimes. And we see that as well with medical labels. And this is a case study out of ARC's Morbidity and Mortality Review, where a anesthesiologist injected vecuronium, long-acting paralytic, in a patient preoperatively that was just supposed to get a relatively simple knee surgery instead of ANSEF, which seems like a pretty obvious mistake. And why would ever anyone make that mistake? When they went and looked at the anesthesia tray where the medications were pulled out, you can see how easy it would be to pick up the wrong red top. And we know from human cognition that if you're anticipating the ANSEF, you could even look at the label and still not pick up that it's vecuronium, especially if you've done it many, many times before. So that gets us to our first case. So how is that all related? Well, we know that humans are fallible. We're going to make mistakes. And if you get a big enough study set, or a big enough population, you're going to see these mistakes happen over and over again. And there might be a 1 in a million chance, 1 in 500,000, 1 in 10,000. But in a large enough health system like MedStar, you'll see the same mistakes happen over and over again. So how do we design those out of the system, and how do we use data and machine learning to help design those things out of the system? So this case study was based on several cord compression cases that happened across the MedStar system over the years. And instead of telling everyone to be more vigilant and say, be careful and go do another training session, they want to try and come up with something that was a little bit more systematic. So for those of you less familiar, cord compressions frequently due to either bleeding or infection in the spinal cord. They can happen up in the cervical spine all the way down and cause cauda equina in the lumbar spine. They're pretty rare, but they're devastating. Patients can potentially die from them, but certainly the worst thing that we frequently see with these is if there's a delay in care, that the patients can be permanently paralyzed. And they often come in with these subtle presentations. Patients will say, well, I'm a little bit weak. I've been dropping things, or I'm really tired. And if we're not attuned to it, then we're going to miss it. And so the idea here was, instead of, again, telling people to be more vigilant and go do another education session, because if you ask a clinician what is cord compression, they're going to know. They're going to know how to diagnose it, but it's that subtle presentation. So Alan Fong, one of our data scientists, helped design with working on a committee, the ability to comb through the medical record as patients present to the emergency department. And actually this screenshot that's up here, I took about 15 minutes ago. I logged into one of our EDs. And this alert shows up. Now, over the years, it's shown up slightly differently, and we can talk about some of the user interface issues there. But this patient presented to our ADT, which is our triage area out in the front of the emergency department, and this alert immediately popped up. Patient only been in the ED for a couple of minutes, and there's already an alert saying, hey, this patient's presenting with some concerning characteristics. It could be history of IV drug abuse plus back pain. It could be weakness and numbness in the legs. There's a number of different things that go into the machine learning algorithm that help trigger this. And the key part is it's front and center, and the clinicians can make a decision. Does this patient really meet those criteria, or is this something that maybe we document on and say, yeah, I've examined the patient, I don't think this is cord compression, but at least it's bringing it up into the differential faster. And there's always this trade-off with, especially when you're using these models, and there's different types of techniques that you can use that are supervised and unsupervised, and how you kind of determine the accuracy of these models. And some of it gets into not just how accurate the models are, but then what is the risk for the system, and what are they comfortable with? Do we want to make sure that we get 100% of cases that were 100% sensitive? Or when the alert fires, do we want to make sure that it's very specific? So if this alert fires, it is definitely cord compression and all hands on deck. And so there's that trade-off, and that gets into kind of policies and kind of back to this human factors engineering piece of what is the meaning of this alert and how do we present it to people? And so that end of that case study. And that tool is actively in use and has been in use at MedStar for a number of years now. A photo by one of my mentors, Robert Weirs, where he took a picture of a bunch of EM residents and nurses and attendings, and kind of this transition between the old dry erase boards that I trained on as we were transitioning to fancy EHR tracking boards that were all electronic. And from that, a whole line of research has been kind of pulled up around the user interface design and these context independent variables like font size, icons, colors, contrast, layouts. We've been studying that for many years and we know how that works. But where we aren't doing a great job in EHRs, or we're slowly getting better, is around supporting the cognitive tasks and those context dependent pieces like workflow design, visualization, memory aids, anticipating errors in the system. So kind of thinking about that chord compression piece where we really need to understand the workflow of those users. So that brings us to our second and last case study. Here we have a screenshot, and this is pretty accurate of what it looks like right now. If I go to type in Tylenol and I want to order Tylenol for my patients, which I do frequently in the ED, I get presented with this list, and there's really no great sorting here. You can try to come up with a strategy, but really it's essentially EHR bloat, that this list has kind of grown over time as new orders have been put in there. But we were finding within the health system that patients kept on getting ordered 650 milligrams of rectal suppository when really the clinician meant to order 650 milligrams of PO Tylenol. And this doesn't happen frequently, but when we started looking at it, it was happening about 1 out of 1,000 times. 1 out of 1,000 times that a rectal suppository was ordered, the clinician actually meant to order 650 milligrams PO. And while you might say there's not a whole lot of difference between oral and rectal O and an R, the patient certainly will remind you and get that caught pretty quickly. And in Tylenol, it doesn't make a difference for the most part in terms of the route, in terms of the effectiveness of the medication. It does have a huge implication for other medications that can be given a wrong route, where you can potentially harm a patient or a patient can die from a wrong route error, all because of the EHR usability kind of creating this risk. We took that example as well as 5 others. We made a series of cases in a system in a build environment, not in a live production environment, ran it across 2 different EHRs, 4 different clinical sites, and saw the same types of errors getting reproduced over and over again, and a lot of variability in the usability of how easy it was to make these orders, like ordering Tylenol, ordering a prednisone taper, apologize for my dog, ordering an MRI for cord compression. And we found error rates as upwards as high as 50%, and when we asked clinicians in a simulated environment to order prednisone taper. And so these were small cases. We had about 60 clinicians that were in this study, so not a lot of data, but it did give us some really good insights. And we went from there and we started looking at how can we understand this across the system? How do we pull in machine learning to really understand the experiences of physicians and nurses in the front lines? And so just like in airplane crashes, there's the black box, which is really orange, that records data. We have a similar system in the EHR that's recording kind of our interactions, our clicks on different things, even video of the interactions, not of us, our faces, but of the mouse movements. And so it allows us to kind of recreate those accidents as they unfolded and really understand what it was about that interaction, that EHR, what was being presented to the clinicians that might have led them down that error pathway. And in the interest of time, I won't belabor you all on trying to find the error here. You can go down, you can look at the highs and the lows and the critical results for the glucose. And most likely you're going to miss the fact that the patient has no white blood cell count here. We're all anticipating a complete blood count would have the white blood count at the top, but in this case it doesn't. Now, when you go back and you look a couple hours later, here shows up the white count. And this isn't particularly alarming, but in some cases, the result could be catastrophic. And if you look over here, you can see there's a little signal over here. This showed up a little over an hour later from the original lab tests. So you could pick that out, but a lot of times the clinicians aren't going to catch that or recognize that there's missing data there. And that kind of lack of usability of that tool leads to it. And so our team is using machine learning techniques to mine through millions of orders to start looking for these types of signals, and we can understand where the errors are happening and why they're happening. So with that being said, those are our 2 case studies, and this is in the last slide here that hopefully will start playing, maybe it won't, where we're really in the infancy of using big data and machine learning in healthcare. And if you look back at car crashes, and I see a lot of car crashes, or the results of such in the emergency department, we see what 50 years of automotive engineering and human factors engineering has done for safety with cars. We see on the right-hand side, this 59 Chevy Bel Air, just kind of totally crashing. You'll see that the glass goes flying, the seat comes off its moorings, the steering wheel is going to crash into the crash test dummy. Just really devastating, catastrophic injuries. And in a second, we'll switch over to the 2009. I don't have any stock in GM, but we'll switch over to the 2009 vehicle, and you'll see. Oh, sorry, no, I say Chevy. We'll see that there are much more safety enhancements. There's safety glass. The wheels are designed to flare out. The car compresses on itself, but kind of prevents the intrusion into the vehicle. And that's why we see patients being able to walk away from these catastrophic injuries, because we've engineered the cars to be safer and to account for errors and the types of kind of adverse events that we might encounter as drivers. Airbag deploying right there as well. So with that being said, it's always a moving target. And so there's always new tests, there's new things, safety standards. And so we have a big amount of work ahead of us. And I'm really excited for you all in your careers and using big data to look at healthcare. And so with that, thank you. And I know I went a little bit over time, but if you got questions, otherwise you can reach out to me. And if you want more details on how we're using the Python and RStudio and all those types of things, happy to have one of our more in detail analysts talk with you all. So thank you for your time.
Thank you so much, Dr. Hettinger. Are there any quick questions that anyone has in the group?
So Alan Balu, is that how we pronounce it? Sent a question in the chat. I'm going to read it. So I'm a new M1 student and I studied computer science in undergrad. I was wondering what opportunities MedStar may offer for me to explore the clinical use of data science / machine learning.
I would reach out to me. My email address is up there. And that's something that we're exploring. What I didn't have up there is that our team has recently released started a new center. It's called the Center for Biostatistics, Informatics, and Data Science. So we call it CBIDS for short. And that's through the MedStar Health Research Institute. And so we're really doing a big push and having a one-stop shop for machine learning. And I've got a number of really smart people that know how to apply machine learning techniques, but we're always looking for those clinical partners. We've got summer research projects. We have research studies that are focused on machine learning techniques that you all could potentially play a role in. So reach out to me if you have like a CV or these are your areas of interest. That'll help me kind of triage which of our team members. But I'll probably connect you with Alan Fong, one of my data scientists who leads a lot of our work and could explore some opportunities. So definitely reach out. We definitely have had a number of medical students over the years work with us.
Thank you.
Thank you.
Thank you, Dr. Hettinger. Dr. Crossley, whenever you're ready.
Yeah, thank you so much, Dr. Hettinger, for that great talk. I'm wondering if there's something in the water in Rochester about human factors, because I'm thinking just like going to a Wegmans is such like a nice experience, and I don't know why. And now I'm wondering if they're like investing in human factors over there. And so, and you're from Rochester, so I couldn't help but think that.
Well, actually, about 10 years ago, a whole bunch of us came down from Rochester. So Terry Fairbanks, the head of quality and safety across MedStar, was my mentor and taught me and started the center. Kate Kellogg, one of the assistant VPs, was one of our medical students. As a fourth-year medical student, did a research project with us when I was a resident. So there was a whole bunch of us that came down. The MedStar, the chief innovation officer, Bill Sheehan, was one of the paramedics that was one of my mentors. So we all kind of came down here. MedStar gave us a great home, and yeah, so short history lesson, but definitely reach out if you're interested in doing more.
Awesome. So there was something in the water in Rochester. Okay. All right. I'm trying to get to my presentation review here. Can you guys see my slides appropriately here?
Yes.
Okay, great. So what I want to talk about is, and cut me off, I think I would have like 15, 20 minutes. Does that sound about right? I probably have more slides than that here. So if I am like going way over, just give me a heads up. But I'm going to talk a little bit more about current applications of machine learning in this subspecialty I'm training in, which is otolaryngology head and neck surgery. I don't have any financial conflicts. I'm going to take a step back a little bit and define, exactly what we're talking about when we say machine learning, and just talk about some principles of this. I know some of you probably have a computer science background, so this may be a bit redundant. Bear with me through that, but I'm going to just talk about some of the ways it's currently being used and may be used in the future. And so some of the projects, I'm not going to get through all of these in otolaryngology head and neck surgery, are, for example, image analysis, for example, determining if a cervical lymph node contains a metastasis that is extending beyond the lymph node, and also auto-segmentation of temporal bone CT anatomy. Other ones I'll probably focus on here. So before we talk about machine learning, we got to talk about artificial intelligence. What is that? It's the simulation of an intellectual task. And so, these examples of autonomous vehicles, games, search algorithms, these are the artificial intelligence. Interestingly, what is considered artificial intelligence tends to change over time. So for example, this, some of the first artificial intelligence machines, played checkers and chess, and now no one really thinks that's advanced enough to be AI. And machine learning is a subfield of artificial intelligence. And these are algorithms that allow a program to learn from data or an experience rather than a hardware to execute a desired action. And in general, and it's a kind of a three-step process. It is trained in a pattern, and is based on a pattern. It is trained to make predictions, and it learns from the data and from experiences. From making accurate or inaccurate predictions, the model will update in order to become more accurate. One example of this, and this can come in several different algorithms and architectures. Some of the most complex ones are these neural networks or these more deep learning architectures. And there's a lot of subfields that go into machine learning, including statistics, obviously computer science, informatics. I think this is a great sort of general depiction of it. And so artificial intelligence is this big whole field of things that are automated. And machine learning is a really, really big part of that, and probably arguably the most important amount. And machine learning can be further subdivided into unsupervised and supervised learning. Unsupervised learning is, for example, shopping recommendations, things that happen without any sort of user input. Whereas like supervised learning is, machines learning to, recognize faces and things like this. And the deep learning is a little bit further. Deep is referring to sort of the layers of the architecture that the algorithm uses. And I think this is probably the most important slide of my presentation because it gives a couple pretty clear examples about two, supervised versus unsupervised machine learning. And so we'll start on the top left. And this is obviously an example from ENT. And so what you can see on the far left here in black and white, these are coronal cuts of a CT of the sinuses. And so in order to develop, developing a machine learning algorithm, what's being done here is on the unlabeled data on the top, you have non-opacified, so this is normal sinuses. Below it, you have opacified sinuses, which are abnormal, and you can see that. And so the human input is really taking this data and giving it a label. And so they're labeling this non-opacified and opacified. And then the more data that is fed into it, and the algorithm is basically generating a function by doing imaging analysis to pick out different features that distinguish what is labeled as non-opacified and versus opacified. And then when the algorithm is trained enough, then eventually your input is going to be unlabeled data. And then as the algorithm is trained and improves accuracy, it should be able to determine between opacified and non-opacified sinuses. Okay, so this is, this is sort of an example of supervised machine learning because you were telling it what are the two options that it can be, from the get-go. Unsupervised machine learning is giving it a bunch of data. For example, these are endoscopic videos of sinus surgery, and on the top you'll see sinus surgery that has not really had any significant bleeding encountered. And below in cluster B, you can see the algorithm may have identified bleeding as a feature that distinguishes a cluster of videos. And then, the machine learning will basically say, here's a cluster of something that's similar, and then here's another cluster of something that is, similar to each other and different from the other cluster. And so the human might say, okay, you've determined this is bleeding and this is not bleeding. And then so then now the machine knows to label appropriately, it's previously defined clusters into bleeding and not bleeding. Okay, so this is an example of unsupervised machine learning. Anyways, my slide here. This is a neuron. You guys are probably familiar with this, but I think this is a good sort of example of basically how these different inputs go into basically make machine learning different than really just basic statistical methods. And so, for example, in a neuron, you have your cell body here, and there's lots of different inputs. Okay, lots of different inputs, and based on habituation and different sort of maturation of synapses, different, and that can be thought of as the algorithm predicting things accurately or inaccurately over time. These sort of connections can be changed, and then the output can be thought of as sort of the output of the machine learning algorithm. And the way a lot of these architectures are built is basically, the strength between things is oftentimes data analysis in the form of mathematical equation, and then stacked into several neurons to produce a highly sort of intricate output. I'll kind of skip over this. Basically, shallow deep learning is the Legos, using mathematical techniques like linear regression, logistic regression to kind of, do these, error and loss functions that will determine the accuracy of a model. And the deep learning is more stacked examples of this. And so I'm going to skip to some clinical examples now. And I think probably most one I think is one of the most exciting is this is from a group that initially started at Yale, and the primary investigator has moved to Boston. And so this is the prediction of extranodal metastases using a deep learning algorithm. The reason this is, and I sort of have a summary slide here. Basically, the problem is, when someone has head and neck cancer, treatment can either be chemoradiation or it can be surgery and radiation. And what you want to avoid, but what unfortunately happens, is what's called triple modality therapy, where someone receives surgery, radiation, and chemotherapy. Okay, because someone who has received all of these things often doesn't have a survival benefit from someone who has had just two. And the reason that this avoidable triple modality treatment happens is because factors that would have led to chemoradiation as the initial treatment are really, really hard to determine before surgery. So because there are obviously, risks of surgery and consequences of surgery, but, chemoradiation also has its own consequences. So avoiding avoidable toxicities is the goal. And so what they did in this study is they basically looked at all these patients who got neck dissections, which is taking out lymph nodes in the neck for cancer, and those of patients who had basically head and neck cancer. And they looked back at their CTs before surgery. And then they constructed a deep learning neural network model. And so this is sort of the nuts and bolts of how they did it. Basically, put the CT scans into DACOM files, de-identified it for RD purposes. And then what they did is they manually segmented the lymph nodes of interest on this CT scan. And then they looked at their pathology results from surgery so they could correlate, the CT appearance of the lymph node and then obviously the pathological results. So A, is there cancer there or is there not cancer there? Because there can be lymph nodes in the CT that look like they have cancer and a cancer patient that don't have cancer. And then more importantly, does it have extranodal extension? And extranodal extension in head and neck cancer is very important because this is an indicator for chemotherapy and it's an indicator for someone who should not get surgery. And it's very hard to tell if someone has extranodal extension before surgery happens. And so basically they took these lymph node images on CT scan, created a coordinate mask, and then basically hypothesized, a 10 pixel area around it that they thought might contain information that could indicate that there's extranodal extension or not. And so basically top left, you have an axial view of a CT. The circle is going around, axial view of a CT neck with the lymph node of the circle around it. Basically, they manually are taking these, masks, segmenting out this lymph node. And so you can see there's a lymph node and then there's 1 and 2. Number 1 is basically it's mapped out onto this, it looks like about 100 pixel plane and it retains sort of scale size. So the algorithm is going to be able to say, hey, this is a big or small lymph node. And then the second one, it basically blows it up to its edges. So, the theoretical advantage of this is you lose the scale, but you can see there's a lot more contrast and potentially more information to analyze than the one that has a lot of basically black around the edges. And this is sort of their architecture, and they actually built this, BoxNet basically is the architecture that goes off of this, fills up the box with the lymph node. SmallNet is the one that uses the small one. And they basically are, where's my architecture slide? They use, basically, they don't do a lot of, sort of original coding for this one. Basically what they do is they took a two-dimensional software and made a few modifications. So really like their technical addition to this wasn't huge. They also added some information about, HPV status, and basically what their output is, your input is this segment of the lymph node. The output is, does this lymph node have extranodal extension, and does that lymph node have cancer? And then, this is their journal. And so, where am I gonna, sorry, I can't see on my slide. Okay, and so basically they needed to, they compared different models. They compared it against benchmark logistical regression, to their deep learning model, which is a statistical model, which uses basically clinical pathologic data. So this is not like a machine learning model. To develop a model that will predict if there's cancer or EME in the lymph node. And then random forest classifier is another machine learning model that they used for lymph node analysis. And here's the results. Basically at the top in that sort of thick line is this deep learning architecture they developed. The area under the curve basically indicates higher areas, more specific, more sensitive. And that area under the curve is 0.9 is very high. And one thing I really wanted to point out here is this dual net model you can see for extranodal extension. On the far left, you can see it 0.88 is it's very sensitive. And it's actually the negative predictive value is very high. So this is really, really relevant surgically, because if you know with high confidence, that a very good negative predictive value of 0.94, you really know that this doesn't have extranodal extension. You can very confidently recommend surgery and know that you're supported by the data here. And when they went to go validate this, basically they took a bunch of CT scans from Mount Sinai and a cancer genome atlas, and they compared this algorithm with like two super expert neuroradiologists. And here's how they did. So basically they had two examples. They did the deep learning model on its own, which is the red curve. And then they had R1 is radiologist number one, and then the star is when the radiologist is using the algorithm to augment their decision. And you can see the accuracy of radiologist number one, basically got better when they use the algorithm, but it's not as good as the algorithm on its own. And then radiologist number two was not as accurate as the algorithm. And when they were given the algorithm to augment their decision, they didn't even get any better. And then, similar results are sort of found on the right for the cancer genome atlas data. And the left is the Mount Sinai data. So, I mean, this is really big. I mean, basically the best, these are the best folks looking at this. And this says basically the machine is more accurate. This has really big clinical consequences when, normally these decisions for surgery or chemoradiation are made with a radiologist, pathologist, surgeon, and medical oncologist at a tumor board conference. And this level of data can help us really reduce the amount of triple modality therapy that are given to folks with potential avoidable toxicities. So this is a really, really big success within our specialty here. How am I doing on time? What do I have, like 5-10 minutes or something like that? I'm going to skip this mod. This one's not as exciting. So this second one here, this is from a group from Brazil, Nieves and Blevins is from Stanford. And this is an algorithm that fully automates CT scans of the temporal bone. And so basically the background behind this is that temporal bone anatomy is very complex. And things like cochlear implantation, middle and inner ear surgeries are highly influenced by anatomical variability. And normally this is done, by this surgeon reviewing the CT scans preoperatively. And normally, surgeons have no issues, identifying things, but being able to fully segment structures on CT, as has been done for, the chest and, the brain, can potentially help develop, simulation models and potentially even automation and help with our our cochlear implant development. And so basically the way they did for this is they used a software called 3D Slicer, which is a segmenting open source software. And they took CTs of the temporal bone, both normal and abnormal, with various pathologies represented. They had experts basically draw on different structures. This is basically the training part of the model. And so they manually segmented lots of structures. And this is very time consuming for people that don't have a lot of time. And so this is something that basically obviously can't be done for every CT temporal bone. Radiologists can give a read, but automatically segmenting someone for whoever's going to read it is basically impossible. And they use that to train this model to take an input of a CT of the temporal bone and segment on its own. And so here's an example. This is the cochlea, the yellow is the facial nerve, the blue is the sigmoid sinus. And then it allows us to show different 3D renderings. And so, for example, this is an example of superior semicircular canal dehiscence, and it actually allows us to give you a 3D rendering, which can potentially help you decide, hey, what kind of graft do I want to do? How big is this defect? We can tell this from the CT of the bone that's not segmented, but these algorithms potentially help us, conceptualize our plan. And interestingly, so after the machine learning algorithm was made, they compared basically the accuracy of the neurotologists who segmented these scans and then the machine learning model. So these are experts rating other experts and the machine. And interestingly, in general, the average that this machine did that they made is better than them. And it actually does it very, very quickly. And I don't know if I have a slide of this. Yeah, basically, these are the time for segmentation, and basically doing this manually takes several minutes. But these deep machine learning models are doing this in a matter of seconds, and that has really big implications for research. A project I'm working with right now, basically I'm using this algorithm that they've developed and giving these segmented scans to surgeons and seeing how helpful this is for them, and potentially creating a library of this to study different pathologies. And this can also be, machine learning models are being used in the voice to detect pathological voices, and in faces for facial aesthetic research. Potential future applications of machine learning include using it as a virtual scribe, surgical approach planning, and potentially intraoperative structural labeling. And to kind of, for some conclusions here, basically machine learning, it's a subset of artificial intelligence. It's really important for our specialty and everyone to really understand the basic principles of artificial intelligence. It really does excel at repetitive tasks and can do these with higher accuracy and speed than humans. And physicians are really important gatekeepers to patient data. And so in order to improve machine learning models, we can potentially help these models get better to help us by telling them what we need and what we're looking for. And this is an example of really how just in otolaryngology, the top is machine learning and otolaryngology, and the bottom is all otolaryngology research. You can see that this is really a hot field in our specialty, and I think it is really big in other fields. One quick thing I wanted to mention, I forgot to mention, is that the big thing about developing these models is the bias in the data that you train it. Models are only as good as the data that you give them. And so it is just a slide of an image, just because I'm talking about imaging, but there was an NIH study where basically they wanted to have a machine learning model that could determine if there's pneumothorax on a CT, or I'm sorry, an X-ray of the chest, because that's something that's like an emergency and basically needs to be treated really quickly. They did this and it was accurate, but interestingly, they found that appropriately, the machine learning model, if there was a needle or a tube in the patient's X-ray, it was more likely to identify that as a pneumothorax, just because the patients with pneumothorax usually had a tube or a needle, because that's how you treat the pneumothorax. And so it was really biased towards even patients who had normal x-rays of the chest. If there was any needle or tube around for any reason, they'll say it had a pneumothorax. So it's not rational, but you know, these models are only as good as the data that you used to train them with. So that's an important point. These are some important resources. Slicer is really good for, this is the open source imaging platform that I was talking about. This group at Harvard who you develop basically these different radiomic packages for use with taking features of 2D and 3D images. There's some codes from that parent lab for Slicer, and then also that Google link has some really good, basically crash courses on machine learning. So I'll take any questions.
I just had one quick question for you.
Yeah.
It seems like when you were looking at the area under the curve for the algorithm, it seems like it performed extremely well. I was wondering, like, what in the ENT field are people starting to adopt some of these algorithms, and what's your sense of things kind of going forward? Because it seems like they're performing really well with validation and these external data sets. So do you have a sense of that going forward?
Yeah, that's a great question. I think it's still very soon. And I think that people who adopt them earlier are going to do better, but people are not adopting these yet. And I haven't, you know, at least at Georgetown, I haven't seen any of the use of this. You know, this group is currently based, I think, you know, at Harvard now. And I think it's very likely that their, you know, radiology departments and their tumor boards are going to use this. And, you know, this is published in the Journal of Clinical Oncology, which is like one of the best like clinical papers. And so, you know, I think the departments of like radiation oncology, I think they're really good about, you know, looking at, you know, they use all sorts of really, you know, sort of fancy software, but from a surgical perspective, I think we're a little bit of a ways off from that. But I think it's definitely coming, and it's really, really definitely impactful research. One thing I will mention in sort of, you know, developing your own machine learning algorithms, one pitfall of it is it's very you guys may know this, it's very computationally expensive. And so, you know, when they develop, you know, machine learning, you know, basically it's running really, 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 really data intensive, computationally expensive code. And it's not the most efficient way to answer questions sometimes. And so sometimes more simple code can be used to more quickly answer a question with a similar level of accuracy. But these models, you know, they can potentially do things that other more things can't. And so if you want to develop a deep learning, machine learning model, you usually need a very, very powerful processor. And so as Georgetown medical students, you might think of, okay, let's reach out to Georgetown Computer Science. And I've done this. And unfortunately, they have like one really powerful, I think it's like a Tesla something, you know, computer. And they won't let you use it unless you have grant funding, because that's how they get their computer time. And so it's just something to keep in the back of your mind, and something why I think it's really great that you guys have brought in Dr. Hettinger, because I think MedStar recently got like a, you know, big money grant that will potentially give them some computing power. But that's something you have to think about with this area of research.
Yeah, no, I think it's all super exciting. I think we're kind of moving forward incrementally from like a research to an implementation to an adoption phase where people are going to start using it. So it's a good segue into kind of why we created the club. And we're really fortunate to have you and Dr. Hettinger with us. And does anyone else have any questions before we wrap up? Okay. Sounds good. So thank you all again very much. We're going to probably send out a recording again. And then if you guys have any questions, or Dr. Crossley or Dr. Hettinger, I'm sure they'd be happy to take them via email.
Yeah.
So yeah, if they want to maybe drop their emails in the chat, but this is us. This is our email address. We're really, again, fortunate to have all of you, and then have a great evening. And thank you so much again for joining us today.
Yeah, thanks guys for putting this on. It's my email.
Thank you.
Thank you.
Great, thank you.